In today's video, we are going over what physical therapists need to know about weightlifter shoulder, also known as AC joint pain, also known as distal clavicle osteolysis. What's going on, guys? My name is Dan Pope. This is Kevin Coughlin. We are both excellent physical therapists. We work at Champion PT and Performance. I think we're excellent, Kevin. And we are here giving you evidence-based information about weightlifter shoulder. We do the work so you don't have to. How you doing today, Kevin?
Oh, I'm doing well. I'm excited for this one. This is a tricky diagnosis and treatment. And I think you're just the guy to guide us through this. So I think this is going to be very informative for folks.
Oh my gosh, people trip all over this diagnosis, right? They have no idea what's coming. They fall flat on their face every time.
It is tricky, and it's like it can be stubborn and it can be very painful too. So yeah, I think this will be good.
Great. All right. So let's summarize our learning points for today. So first, we're going over what is distal clavicle osteolysis. If you're a physical therapist, it might actually be the first time you've ever heard this before. It's an interesting diagnosis. And what populations do you see this in? So, spoiler alert, weightlifters. We already talked about that. What is the anatomy and pathophysiology of DCO? What should your clinical examination look like? What is that differential diagnosis? Just make sure we're treating this accurately, right? Maybe it's something different. We've got to make sure we don't miss things. And then what about treatments? What do we do from a conservative perspective? Do we exercise it? Do we do bed rest, right? Because that might be a thing. Do we intervene with things like injections? And then lastly, do we have surgical options when conservative treatment fails? And this is kind of a full circle moment for me because I've been talking about weightlifter shoulder or DCO for years, right? Very, very common in weightlifters, not very common in other folks or other populations. And if you went to PubMed and you started looking through PubMed, there's never any good research on it. But what I will say over the past few years, we've gotten more and more, which is pretty cool. And there was a study in 2023, which we're going to be going through, called a Sports Medicine's Clinician's Guide. I think there's too many S's there, to the diagnosis and management of distal clavicle osteolysis. Lead author was Singh in Current Sports Medicine Rep. And like I said, this is a 2023 article. And largely, there's not a ton of research on this, but this study actually did a decent job. So a lot of the information today is going to come from this paper here.
I've been afflicted. Oh, I think it's the dreaded weightlifter shoulder. That's the problem when you're so jacked.
Oh, hey, this looks like it would be useful. An evidence-based cheat sheet on the treatment of weightlifter shoulder, huh? Oh, get up to date under 10 minutes? I have a really hard time staying up to date, and all of the information is coming out here about different pathologies such as weightlifter shoulder. This looks like it's extremely useful. Oh man, it goes over all the most relevant information about weightlifter shoulder or distal clavicle osteolysis, like the definition, risk factors, clinical examination, and best treatments. Yes, this is Dan, the author of the evidence-based cheat sheet for weightlifter shoulder. And yes, all of that is true. I will get you up to date on weightlifter shoulder in under 10 minutes. Best of all, this is 100% free. And it's super easy to download. All you have to do is click on the link below in the description. Go ahead and download that and get learning. Kevin, you got anything to add before we get rolling on this hot topic?
I do feel like you've been talking about this topic for a long time. So I think this is going to be a Dan Pope masterclass.
Oh, we'll see. Hopefully come out smarter, not dumber. Okay, so first and foremost, what is DCO? Generally speaking, it's AC joint pain of a particular variety. We'll talk about the anatomy in a second. It's due to repetitive microtrauma at the distal clavicle, particularly during movements like bench press. It consists of increased osteoclast activity. I don't know if you guys remember the whole osteoclast, osteoblast. Osteoclast breaks down material. Osteoblast builds it back up again. So at the distal clavicle, you've got a breakdown of the bone underneath of the cartilage, right? So like I said, it's an injury to the subchondral bone. So what's a bit interesting about this is it's different than just AC joint arthritis. AC joint arthritis, one of the aspects of this is having a lot of breakdown of the cartilage. What's interesting about DCO is kind of breakdown of that subchondral bone, right? So the bone starts to wear down on the clavicular side. And the theorized mechanism of injury is hyperextension and hyperhorizontal abduction of the shoulder. So think about bench press, especially with a wide grip. When we bench press, those shoulders, the elbows are up to the sides. We're going into horizontal abduction, and that's going to place excessive traction on the AC joint. So one of the thoughts is that you are pushing that joint together and then it gets rubbing, basically. So it's micro trauma to the distal clavicle over the course of time can create pain. And what's really interesting is there's a strong association between DCO and weightlifters. Not necessarily Olympic weightlifters, although these folks can certainly get it, but I see it a lot more in folks that bench press, push up, dips. Those are the big ones that tend to get this. And what I will say is that this is not common at all in the general population, but in the gym, this is super common. I would say that this sometimes rivals things like rotator cuff related pain as a source of pain in people's shoulders. If someone comes in, they're like, yeah, I got a lot of pain in front of my shoulder when I bench press. One of the first things I'm thinking is like, all right, is it right on the AC joint or is it kind of off the AC joint? And right away, I'm thinking, is this more that distal clavicle or is that more kind of rotator cuff related pain? This is one of the things, one of the reasons why I was so frustrated for years. There's like no research on it, but it was just seeing it all the time, you know? So I do think if you work with a lot of people that like to bench press, you're going to see aggravated AC joints, right? That's going to be something you see. Boom. Any thoughts there, Kevin?
Yeah, in terms of the mechanism of injury, so you're saying you're seeing it at the bottom of the bench press when there's that hypertraction. So do you ask folks like what part of the pressing motion are you getting most of your pain? And if they tell you something, does that make you think more likely to be this distal clavicle causing the pain?
That's a good question. You know, I actually thought the question was going to end a little bit differently. I would say no, just because broadly, the bottom of the bench press usually hurts folks more than the top across like most pathologies. I think the reason being is that as you descend into a bench press, the moment arm for the shoulder increases until about the sticking point of the lift, I'd say. Like I'm not a, physics specialist, but largely as you bend at the elbow, the shoulder just has to do more and more work. So we think about the different pathologies in the shoulder, rotator cuff, pec injuries, like AC joint pain, all of those in common share that as you bend the elbow and the bar descends is more strain. So most of those pathologies are going to hurt more as you go deeper into the press. Now, based on that theorized mechanism of injury, maybe the very bottom being most painful makes sense from the mechanism of injury standpoint. But what I will say is that if you've got pain in the bottom of the bench press, that's just common in most pathologies. So yeah, I thought you were going to ask if it makes you modify your bench range, which, spoiler alert, yes, probably initially.
Mm-hmm.
Does that make sense?
I learned about that in the fitness pain-free certification.
Who's that? That sounds like something that might be worthwhile.
I think that's a great course, great certification, and it will teach you all about this.
You heard it first from Kevin Coughlin. You should buy the fitness pain-free certification. All right, let's move on. So a little anatomy, guys. If you haven't seen a skeleton before, this is a skeleton. And you've got your clavicle, right? So distal clavicle meets with the scapula or the acromion, right? So AC, acromion, clavicle. And you see that little red part there. It's a little tough to see. It's very small, but that's basically the AC joint, right? So in folks that have distal clavicle osteolysis, they end up having some wearing of the subchondral bone on the clavicular side, right? So we'll get to this in a minute, but these folks will report pain and tenderness on that clavicular side, not so much on the acromial side, right? And what happens over the course of time is that you will wear on the distal clavicle to the point where the AC joint actually widens. And when you take imaging for these folks, like an X-ray, you see extra space between the distal clavicle and the acromion. And that's one of the ways they'll actually rule in DCO, because your body is just kind of eating away at that clavicle due to that micro trauma and stress over the course of time. Pretty dang interesting. So next, a super sad study for you, Kevin. Are you ready just to be sad, sad, sad?
Hit me with it, Dan.
All right. So this was 2016 study, that fateful day where our hope was ruined, called distal clavicular osteolysis in adults, association with bench pressing intensity, right? Cool study. Like I said, sad study. A couple keynotes from the paper. So 56% of the patients in the study, there are 262 patients with DCO, were high intensity bench pressers. And they defined high intensity bench pressers as having your 1 rep max more than 1.5 times your body weight. So if you weigh 200, you're a beefy 200-pound male, and you can bench press 300 plus pounds, your likelihood of DCO went up a little bit. Pretty dang sad. Compared to only 6% in patients without DCO. So if you're not very good at bench press, good, less likely to get DCO. However, big bench press is one of the most important things in life, Kevin. What are your thoughts?
Yeah, I think that's very accurate. That's the only reason I bench press.
Yeah.
And I do have this pain. So
yeah.
No, that's interesting. I mean, yeah, I mean, you hear stuff like that, but you weigh the pros and cons of bench pressing and the other fitness benefits it has. And, you know, I think it pays off to bench heavy. So what are your thoughts?
My thought too is like, I'm always measured about these things. I think in social media, you get like two ends of the spectrum. You got like some of the surgeons are like, you should never bench press. It's bad for your shoulder. And on the other end of the spectrum, like bench press is the best thing you could possibly do. You should never stop doing it. Right. And I think the answer is probably somewhere in the middle. Like if you go crazy on anything, it's going to increase the likelihood that you have longer term problems. Right. And it's funny because anecdotally, I've seen this so much. Heavy bench press is like the thing that hurts painful shoulders. Right. And now we have a little bit of research to show that. And I'm not changing my opinion on whether or not I should bench press. I think you should. I think it's good for you. I work with a lot of powerlifters. They're not going to stop bench pressing heavy, nor do I want them to. But maybe we can be a little bit smarter about the way we train in the future and also the way we rehab these folks. So I'll try to give some ideas on the future. But it does seem like this intensity thing is a major risk factor, unfortunately. So we just said this, but in this study, they found that high intensity bench pressing was a risk factor for DCO. Low intensity bench pressing, which they defined as 1 rep max, less than 1.5 times body weight, was not a risk factor for DCO. So if you weigh 200 pounds, you're a swelty male, and you bench press less than 300, you're not quite as at risk. And that's a decent amount less, 6% versus 56. It's kind of crazy. Other factors they found that were related to DCO was a high frequency of bench press, so bench pressing more than 1 times per week, and also having been bench pressing for a longer duration. So greater than 5 years of bench pressing increase your risk of DCO, which makes sense. It takes a while to develop DCO. And I think one of the things that's an absolute no-brainer that most of the injury stats show us is that if you bench press for a longer period of time or you are exposed to a sport for a longer period of time, your risk just goes up, right? You're more likely to hurt yourself playing soccer, right? When you play soccer 10 times per week than you are to get hurt playing soccer when you sit on your couch all the time, right? You just have way more exposures to it, so you're more likely to get hurt. And this is the case for bench pressing as well. I also think that there's some sort of argument to be made that your shoulder joint might not be able to recover. So that dosage might be too high if you're bench pressing 2, 3, 4, 5 times a week, which this is all anecdotal, but I grew up in the West Side era, which in West Side programming, essentially you bench press heavy 1 day per week, and that's it. The other day you do more speed or accessory work, right? And that was very common. What we're learning now is that higher volumes generally lead to more strength. And there are a lot of powerlifting programs out there right now, and they're not new, but I would say they're newer in the United States, that people are bench pressing 2, 3, 4, 5 times per week. I think the reason why they do that is because it's raising their benches. They're getting stronger. But I also tend to see some more shoulder pain. And that just freaks me out a little bit because obviously I want to keep these people training. And you get in this place as an athlete where every time you start to ramp up the volume, you get hurt again. And then you have to rehab. And then you start to ramp up again, you get hurt again. So that's a big problem, right? So a little bit more about this study so I don't get more on a tangent. In bench pressers who suffered DCO, the mean 1 rep max was 283 pounds compared to 209 pounds in bench pressers not affected by DCO. So this was not an elite bench pressers. You're not looking at 500, 600, 700 pound benches. You're looking at the average meathead in the gym that's actually fairly successful in the bench press versus folks that aren't as successful. And my other thought with a study like this is like the people that are bench pressing a little bit more probably care more about bench press. If your bench press is higher, you're probably hitting it harder in the gym, right? Like I was a meathead in college and I cared only about bench press weight. That was like the most important thing in my life at the time, which is kind of funny to think about, right? Didn't care about, future career, didn't care about my friends, just cared about the bench press. Kidding aside, bench press was very important. I think this is huge for a lot of other folks. If all you care about is bench press, you're going to push really, really hard. And your chances are you're going to have a higher bench press. For the folks with the lower bench press, they probably don't care as much. My thought, and I'd love to see future research on this, is that the folks that don't care as much about bench press probably aren't pushing it as much. They don't put as much weight on the bar. Their rep and reserve is probably going to be greater. The RPE is not going to be as high, right? So I wonder if it's just the weight on the bar, or maybe the intent, the rep and reserve, the RPE, all those factors. I'd love to see a little more research on. That's just what my gut tells me, having been like a big bench presser for years and years. Anything to add? Obviously, I feel way too passionate about this, Kevin.
Have you seen in the research or anecdotally a difference between straight bar bench press and something like a dumbbell bench press? Does that seem to affect who's getting this, or is it purely a pressing motion with intensity?
Mm-hmm.
What do you think about that?
No research on this, right? B, the authors do make some recommendations in this study, but I don't think dumbbell bench press is one of those. C, I see it all the time. Bench press is just that motion that tends to hurt people. And the number one modification that people make when their shoulder hurts during the bench press is usually dumbbell press. You're like, you know what? Bench press hurts my shoulders, and that's why I just moved over to dumbbell press. Mm-hmm. You know what I mean? It's funny because I'll get some patient comes in the door and they're like, yeah, I can't press. It hurts too much, right? And then I go, okay, well, I can't bench press. That makes sense. How about dumbbell press? Have you tried that? He's like, oh, I dumbbell press every day of the week. Like, it feels great, right? It's like almost people don't recognize that dumbbell press is similar to bench press. It's like an accessory exercise that, they just do when they have shoulder pain. So yes, I would say anecdotally, I see a lot of folks switch over dumbbell press, and I hear that all the time, that dumbbell press feels way better.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms, or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
So how about clinical examination? What should you ask these folks as they come through the door? What are they likely to say? And then objectively, what you should do with these patients to kind of rule in that diagnosis or rule it out. So generally speaking, these folks in their late 20s and early 30s tends to be more males than females. I think that this is just the age group that really cares about lifting weights, right? I will say anecdotally, when I kind of hit my mid 30s and I, having kids, career, all that stuff, weightlifting kind of took a little bit of a hit in terms of importance for me, although it's still very, very important. So I think that that effort that went towards building an enormous bench press went down. So that really makes a lot of sense to me from a population perspective. Males greater than females makes total sense. If you ever go to a gym and you look at the exercises that women are doing, it's going to be more lower body. If you look at the exercise that men are doing, it's going to be 90% bench press, right? It's like bench press and biceps. We all know this, right? Obviously, I'm being facetious here. Women do bench press too, but bench press is usually more important to men from a cultural perspective. So that makes sense. These folks will usually have a dull aching pain right over that AC joint, and it's generally exacerbated by weight training. So like we said, bench press, but also push-ups, dips, also potentially shrugs. Think about the upper trapezius, crosses over that AC joint, might create a little irritation there. Military press, as well as clean and jerk. Clean and jerk is an interesting one to me. For one, when you do a clean, you're catching the bar on your clavicles and deltoids. So you're putting kind of this inferior force on the clavicle, which could be causing some shear in the AC joint. And that might be one of the reasons why we're creating some distal clavicle osteolysis. Just a thought. I'm not sure if that's the mechanism, right? Typically feels worse after training. These folks feel pretty dang good throughout their regular life. It's just that when they go to the gym, it hurts. Okay. That's pretty common for them. If they stop weightlifting 100%, they probably feel pretty dang good, right? This is often something that creates pain while sleeping, which is similar to a lot of other shoulder problems. So make sure you do your due diligence from a differential diagnosis perspective. Tends to hurt more when you have the arm adducted across the body or flexed overhead. Think about your typical test for AC joint pain. Horizontal adduction, flexion tends to aggravate it. If you sleep in those positions, makes sense. These folks may have a small degree of swelling on the AC joint, although it's not always common to have a lot of swelling. Rest typically helps, and then it typically comes back with training. These are the folks that tell you, like, you know what, I stopped doing bench press because it hurt me so bad. Rested, felt a bit better. When I went back to bench press, just starts hurting again. All right, very, very common to hear that. These can be atraumatic or traumatic. We just talked about that atraumatic kind of gradual onset just from that kind of micro trauma over the course of time with a lack of recovery. However, these can also be associated with an AC joint sprain. If you fall, sprain your AC joint real bad, that may increase the likelihood of you starting to acquire this DCO, right? So make sure you're asking those questions of your patients. Hey, did you ever sprain the AC joint? Take a look at it. Is it kind of bigger or elevated on one side, right? You can use that as information to try to rule in or rule out DCO. Anything catch your eye there or catch your ear?
Yeah, I think everything you said there is what I see in patients who end up developing this. Another question I had for you is that, I know that one of the classic tests for AC joint pain, like you had said, is kind of that like reach across, and a little bit of adduction and flexion of the shoulder can be painful on the AC joint. And then in the mechanism, we talked about how it's like a hypertraction force that you might get at the bottom of a pressing motion. So do you feel that, or do you find that both of those spectrums of traction and compression with the tests like the adduction and flexion are both going to be painful? Do you see one be more painful than the other?
Yeah, and it's funny. When I read through that paper for the first time, because I think I'll have a link in the show notes on this, but they are basically talking about an older paper. It was like 2000, early 2010s, I think. And this is all theory. They don't really know exactly what creates this trauma within the AC joint. And when they say traction, sometimes they mean distraction and sometimes they mean compression, right? So I've heard that term used interchangeably, and it's not like I reach out to authors to see what their thoughts are, right? But what I find is that if you take these patients and put them into horizontal abduction end ranges, unloaded, it doesn't hurt, which from a distraction perspective, essentially that should hurt if the mechanism of injury is pulling that joint apart. I think, and again, I have no idea, I'm just guessing, haven't seen this a lot, that when you're bench pressing, you're probably compressing that joint quite a bit. It probably goes through a period of maybe unloaded and extreme horizontal abduction, and immediately back into being compressed, right?
Mhm.
Deltoid pec, all those muscles cross over the shoulder joint. They're probably going to create a lot of compression within that joint. So if it's going from kind of unloaded to loaded and it's being compressed, I think it's like a similar mechanism of injury to, like, let's say I'm squatting a lot and I get patellofemoral pain. I'm just kind of mushing that joint together. If I do that excessively, can irritate that subchondral bone, right? And what I will say is that unloaded, these folks feel pretty good. It's as soon as you put weight in them, in their hands. So you may not be able to provoke these at all, but then you go out and bench press, like, oh, there's my pain, right? So that answer your question?
Yeah, perfect. Yeah, I think that's important that, folks don't get tripped up on that. You can see it on both ends a little bit, but the compression makes sense for sure.
Yeah, for sure. I should probably go and ask those authors, you know what I mean? But I think it's all theorized at this point. We don't know. It's kind of like we're talking about what's the mechanism of injury for slap tears. Is it peel back, end range ER, external rotation? Is it follow through, right? Is it more compression based? I'm not sure. I'm not really sure what that is. It's kind of our best guess. There's no cadaveric studies like we have in slap lesions. You know what I mean? All right. So objectively, what should your exam look like for these patients? So tentative palpation at the AC joint, right? And this is like the first thing I ask my patients. And if I take them out in the gym to bench press and they say, oh, yep, that's my shoulder pain, I'll put my finger right on the AC joint. It's like, is the pain coming from right here? Oftentimes I'll say, yep, right in that area. And that really increases my likelihood of thought that this is the AC joint, DCO. If they say, no, it's actually a little bit lower, I'm thinking a little bit more rotator cuff related, or maybe a little bit more of the biceps. We haven't done a ton of research in DCO, so I can't like rule this in and say this is the most sensitive and specific test, but this is like a no-brainer. Like if you hurt right over the AC joint, like I'm thinking it's more DCO, right? Personal opinion. I'm not sure. The other thing is these folks may have pain, end range flexion and end range horizontal adduction. Those are the movements that tend to provoke the AC joint after an AC sprain, right? So that makes sense. From a special test perspective, do we have anything specifically that we can use to help rule this in? Well, the authors kind of thought the active compression test of O'Brien might be helpful, because the thought is like, okay, we are compressing that AC joint when we do this. So essentially flexing the shoulder to 90, 15 degrees of adduction, maximal internal rotation, and then resisting flexion. From an imaging perspective, and this is pretty interesting, you can go on online and you can kind of research this yourself. These are all copywritten images, so I can't put these onto the presentation here. But you will notice via imaging that the subchondral bone has some edema on it on an MRI. The other thing you'll notice is the AC joint starts to widen. So as that clavicle loses bone, as we stress that subchondral bone, the joint gets larger and larger and larger. And it's because the clavicle is kind of receding, which is really interesting because, like, I'm getting ahead of myself, but the surgery, you just kind of lop off the end of the bone of the clavicle, and that really helps folks with pain. But your body is kind of naturally doing that already. It's just kind of like getting rid of that bone. And then the other thing you can consider, and I see this a lot in patients actually. So when people have this kind of dull anterior shoulder pain, they're trying to differentiate between, is this maybe labral? Is this the AC joint? They'll inject right into that AC joint and they'll say, hey, does that get rid of your symptoms? Right? And if it does, you're thinking, okay, this seems like the AC joint, which is obviously important if you're thinking about getting surgery for this, right? Because the treatment for labral pathology as well as treatment for DCO, very similar in my opinion. So we don't necessarily need it as much from a diagnostic perspective, but if you're about to get surgery, let's make sure we're doing surgery on the right thing, right? And they can also inject into the joint to see if that's more labral. That gets rid of your symptoms. We're thinking more labral, right? The other thing is that, getting ahead of myself, you can use that as a treatment as well. So if patient's not getting better, something like a cortisone injection may be useful. Any thoughts on that before we move on, Kevin?
No, I think you nailed that pretty good. I think I see similar things. Palpation is definitely one, and kind of those like end range passive motion things tend to be painful as well. So I think that can guide you pretty well.
I feel like I'm a hammer today, just hitting all those nails. I'm like a roofer, just pounding the nails into the roof. It's a pretty dumb analogy. All right. Now the good stuff, treatment. How do we treat these? Who knows? Your guess is as good as mine. It's kind of sad because we don't have established treatment protocols at all. Like literally there's nothing that you can find in PubMed that will say, this is a randomized controlled trial of folks who have DCO. Here are the exercises that have been used. Or this is a study looking at an established protocol treating DCO against another protocol to see which is better. We don't have that type of research the way we have that in different tendinopathies, right? So it's really hard to tell. So this was basically the author's opinion, and I'll also tell my anecdotes and how I tend to treat this. Like I said, I'm going to have some really in-depth case studies inside of Insiders in the future, so you can check that out. But the first thing they recommend is some sort of activity modification, right? Which I'm a huge fan of modifying exercise in the gym when you have pain. So the authors recommended eliminating offending exercises for somewhere between 4 and 8 weeks. And this is not how I typically do it, although maybe this is the way to go. So when someone has pain throwing, one of the first things doctors do, they'll take away throwing, right? When people have pain bench pressing, take away the bench press. It makes sense, right? What I typically do is I try to find a way to modify the bench press if I can. And oftentimes, if we reduce the load, we can do this in a variety of different ways. So we can, I think probably the first thing I try is to change the rep and reserve or the RPE. So if people are going close to failure, now I give them up to 4 to 6 reps in reserve. We have some research to show that 4 to 6 reps in reserve will give them a similar improvement in strength as going to failure, which blows my mind. Oftentimes I find these folks just going way too heavy, right? And if their goal is to improve their strength, we know that we can reduce the load and improve at the same rate or even greater. Some of the recent studies are showing that if you go to failure, your improvement in strength is actually worse than if you keep a few reps in reserve. So a lot of folks just drop down that rep in reserve or increase rep in reserve, drop the RPE, and they start feeling a little bit better. Let's say it's not working. We can change the rep range a little bit. So let's say we increase the reps from 5s to 10s. Automatically, the load has to go down in order to do that. People sometimes feel quite a bit better. You can also try slowing down the movement, adding a tempo. If you add a tempo on the way up and the way down, load is going to have to go down. Oftentimes, these folks are really good. And if someone's not making a lot of progress with that, then I just change the exercise a little bit. That's oftentimes maybe changing the grip. So something like a close grip. Maybe we try a Swiss bar, right? Maybe we switch to dumbbell, so on and so forth. I'm not going to go super in depth on this because I've already done that in a lot of videos. And we'll leave a link in the show notes. If you guys want to see my favorite modifications for folks with AC joint pain, I'll leave that in the show notes for you. The next piece that I thought was interesting that I'm not really sure about was the authors noted this is a bone injury, right? And should we be treating this kind of like a stress reaction or a stress fracture? What are your thoughts on that, Kevin? Because I thought that was really interesting when I saw it.
Yeah, that is. I think I'd want to see some research that kind of pans that out. Like if they do that, but that does follow a similar kind of treatment algorithm of reducing loads and then slowly exposing the joint to ever increasing loads. So that, that approach makes sense. But I wonder if it, I think when we're talking about a stress fracture, we have to really reduce loads, like you know, if we're talking about like a lower extremity stress fracture, sometimes non-weight bearing. If we're talking about like in the spine, sometimes they're braced and they really can't do any activity besides daily activities of living and be really cautious. So I don't know if we have to unload that much for these folks. I think like you had mentioned, you do a really good job of keeping them doing the highest level of activity that they can tolerate. So maybe it's just something as simple as reducing the amount of load they're lifting, working at, a little bit higher rep and reserve than those folks who are maxing out all the time. And in that case, I would think of that very differently than a stress fracture or a stress reaction. But, I understand it is bone and I understand, kind of the thought process there, but I'd have to see that folks are so limited that we have to treat it like a fracture before kind of taking measures that drastic, I guess, is what comes into my mind.
Yeah, that's, when I first thought that, I was like, oh, that's pretty smart, right? My second thought was like, I've been treating this for years and I don't do that.
Hmm.
So it's interesting. Would it be better if I offloaded more? Maybe. It's hard for me to know. I would say that I use pain monitoring model, and I think that having a little bit of pain is acceptable. And I've had quite a few successes over the course of time with that. So maybe I'm doing it completely wrong, but that's typically not how I treat these, for better or for worse. So next thing that the authors recommended, and I just already said that I use this, I think it's smart, is that you can modify your activities. And a few things. One of the things that they said was to narrow your grip, which makes sense. When we go narrow grip, one of the things that happens is you go from a more horizontally abducted shoulder position to a more extended shoulder position. And the thought is that that may reduce some of the strain on the AC joint. Anecdotally, I find that a lot of folks will naturally go to a narrow grip and feel a bit better. We can also reduce that range of motion, which again makes a lot of sense. We're reducing the time spent in the very bottom part of the bench press under load. So if I do a pin press, I do a board press, I just don't go down all the way. That can be helpful. One of the things I tend to use for these folks is accommodating resistance. So chains or bands. Chains or bands, essentially as you press towards lockout, more of the chains come off the floor, it gets harder. There's more band tension. So essentially what happens is that it's easier at your chest, where typically folks have more AC joint pain, and harder during lockout. So that's another potential option you can try for some of your patients. But in the study, they just talked about narrowing the grip, reducing the loads, and the range of motion. But those are some other options you can kind of try. What are your thoughts? Do you ever use any of those, Kevin?
I didn't, but I do now since doing the fitness pain-free certification. No, I think those are great modifications, like we just talked about in terms of treating it like a potential bone stress injury. You know, I guess you got to weigh the pros and cons. Like, is the goal absolutely zero pain? Then completely unload them. But most folks aren't going to want to do that. Like, as an active person, if I have the option of continuing to train with less pain and you're telling me about this pain monitoring model, and I can work out and do the lifts I really enjoy in a 1 or 2 out of 10 pain, and I can do something like a narrow bench press, or I can do something with chains or bands and get a good training effect, I'm going to take that a million times out of a million versus completely unloading, right? There's no way I want to be sedentary for months until this goes away. So, you know, if you can keep me training and I can feel better doing something like that, I'm going to buy in and do that a billion out of a billion times.
A billion, yeah. Obviously, I agree with you there. I just thought it was funny, your choice of numbers. Yeah. 17.2 times out of 17.2 times. Sorry, that was really dumb.
I don't know where that came
from. That's a lot of times you might try it. Dude, every single time. That's confidence right there.
Yep.
Confidence. Okay. So going back to treatment, were any rehab protocols useful in the medical literature? Nothing studied, right? So what the authors of this paper recommended was to treat this like an AC joint injury, which I think you can do that, right? It makes some sense. My big caveat to that is make sure that you keep in mind these folks are weightlifters. AC joint sprains are common in other sports. So hockey, lacrosse, people kind of getting checked, falling, separating the AC joint. What they're trying to get back to is going to be very different than a powerlifter. So my thought is that make sure you treat these folks like weightlifters if they are weightlifters, right? Don't treat them like a soccer player, hockey player. If they aren't one of those guys, if they are, certainly do that. So how do you treat AC joint injuries? Generally speaking, AC sprains, you work on improving range of motion, strengthening the cuff, addressing any dyskinesia that might be present, working on muscular imbalances, which I think some of these are, strategies based on older research too. We know those are kind of nuanced a little bit. They recommend strengthening the deltoid and the upper trapezius. That makes a lot of sense. Those are muscles that stabilize the AC joint, right? I think those are oftentimes undervalued areas in our medical research, right? When people have shoulder pain, it's like, all right, get the cuff going. Upper trap is too active. Keep that relaxed. I was like, well, I don't think so. We probably want to make sure the upper trap is nice and strong. It does stabilize that joint. The delts are important. Oftentimes we vilify the delts. So like, oh, delts are too active. Cuff is not strong enough. I'm not saying not to strengthen the cuff. I think we should. I just think that it's probably wise to make sure you're focusing on the delts as well as upper trapezius as well, right? And then essentially my thoughts, so this is not coming from the research paper, so take it all with a grain of salt. I think you should modify your training with these patients. I think you should strengthen the structures that surround the area, so delts, upper trapezius. I think you should have a slow ramp back the training over the course of time. It's reasonable. I think you should employ some potential load management strategies throughout the course of the year, like potential exercise modifications. If I'm a power lifter and I have so much trouble bench pressing because my AC joint just flares up so badly, then maybe we can consider having some sort of in-season and some sort of off-season in your training year. Let's say you have a 3 to 6 month buildup to a meet, which consists of increasing the frequency of bench press, increasing the intensity of bench press. We ramp up for it. We compete, we hit a PR, and then we back off again for the next 6-ish months, where we focus on different exercise variations, maybe more Swiss bar, maybe a little bit more close grip stuff. Maybe we keep the rep ranges a little bit higher. Maybe we reduce that total frequency of pressing variations throughout the course of the week. And then when we ramp back up into our competitive season, we just do a little bit more, right? I know for myself, over the course of time, I've kind of figured out my limits in terms of how often I can do the main lifts. For me in the squat, I've had a love-hate relationship with this movement because it's always been the weakest point in my training, right? In comparison to like my bench press or my deadlift, right? Or my overhead press even. And my solution was always do more. And I've always gotten more pain, right? So I've kind of found over the course of time, my sweet spot is squatting 1 or 2 times per week. If I start going above that, my hips get cranky, my low back gets cranky, my knees get cranky. I have to be a little careful with that. So I just recommend this to my patients because a lot of the patients I deal with, they want to get stronger. They want to do more, right? They're willing to work harder. But every time they do, they just flare up their pain problems. And then they get weaker. So you do this yo-yo all throughout the course of the year and they make no progress. It's not good. So let's back off a little bit on the frequency, make steady, slow, consistent progress. Remember, the West Side guys, they bench pressed once a week and they produce some of the strongest pressers in the world, right? So maybe we don't have to do a high frequency of bench press in order to get better, right? Is more volume better generally? Yes. But can your shoulder handle it? And that's one of the things I talk a lot to my patients about. Because long-term, we want to make sure that we keep doing things we love for the long term and make sure that we're also increasing our strength and performing well from an athletic perspective. So, yeah. Any thoughts on that, Kevin?
Yeah, no, all good stuff. I think you nailed that treatment approach.
Boom. Hammer.
Nailing it. Yeah, no, nothing to add there.
All right. What do you do when, you know what, physical therapy is just not cutting it? We're not making progress. What do we do? So you have a few options. You could do surgery, and you can also consider some injections. Now, what do they do from a surgical perspective? Surgery called a distal clavicle resection, and it's exactly what it sounds like. They just chop off the end of the clavicle, which is always wild to me because it's like you're just taking off one side of the joint. And it's kind of like, isn't that important, right? But here's the thing: they have really decent outcomes, and I'm sure you've seen folks that have a pretty bad break of their clavicle, and they just kind of let it stay there, right? Like, well, if we do surgery, that might lend itself to some problems. So we're just going to keep it broken. And then folks don't have a connection, right, from their skeleton to the scapula. You're like, that seems like it's bad. But those folks actually tend to do fairly well. And what's cool about the surgery, it's got a 3 to 6 week return to sport. It's a very, I don't know, easy surgery, I'll say. What I will say is that we need more research on this, right? Like I said, there's not a lot of research on DCO, but the studies that do exist show some pretty good outcomes. In the study I included here, the participants returned to bench press, military press, incline press, and their strength was maintained 18 months post-op. So at least that sounds good to me. They're getting back quick and their strength is maintained, which is pretty cool, right? Now, if we don't want to go down that route, is there anything else we can do from a more conservative standpoint? Well, we have a few options. Corticosteroids, like I said, and maybe some orthobiologics. What does the research show us on corticosteroids? Well, they've got an up to 93% success rate, depending on the study you look at. And the problem with this is your symptoms return generally after 20 days, which makes total sense to me. If you have a patient that comes in, ton of pain in the AC joint, they just go in, they get that steroid injection, they feel great, they just go right back to what they're doing before, of course it's going to come back, right? And that makes sense to me. Corticosteroids are very rarely something that just automatically makes things better. So I think for these folks is that we probably just need to make sure that if we give them a corticosteroid injection, we're also backing them off, getting them stronger, ramping them up slowly over the course of time. Folks in this study, they weren't doing that, right? I'm thinking that things would be different if we did. That'd be my recommendation, although obviously I don't know. The other potential treatment are orthobiologics. The new kid on the block, so stem cell treatments, PRP, so on and so forth. Are these effective? And to be honest, we're not really sure yet. I did find a case study, which again, terrible evidence in the hierarchy of things, but it did seem that, at least in that case study, PRP was something that is effective. So if I have a patient that doesn't mind doing something that's experimental, really doesn't want to do surgery, had no success with corticosteroids, no success whatsoever, physical therapy, and they really don't want to do surgery, then yeah, I might recommend something like that. But to date, we don't have a ton of great research. Any thoughts on those strategies, Kevin?
Yeah, it's always exciting to see the orthobiologics progress a little bit over time, and who knows if they're going to be helpful in the long run. But like you said, there are patients that are willing to experiment, um, especially when you see something like steroid injections may be helpful, but only for 20 days till symptoms return. That's not what most folks are looking for. And we do see steroid injections come sometimes with um, other issues that come along with them. So yeah, I'll be interested to see how the orthobiologics progress in the future. I'm sure there'll be some cool things down the pipeline.
All right. Now that you're an expert on the evidence, it doesn't really exist for DCO. You still might not know how to modify the bench press. So folks can do two things. A, keep working towards their bench press goals. B, rehabilitate at the same time. If you do this accurately, I think you can actually accomplish this. And oh, whoa, do you see this? Over top of Kevin's head, a link just popped up to a video where I go over my favorite modifications for the bench press and folks that have DCO. Go ahead and click on that, and I will see you in that video. If you're watching this on YouTube, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.